Morning. Thank you for tuning into our session today. I'm John Mitchell, and I'll be sharing with you some thoughts on CME. What is the evidence that it works? I'm grateful to the AUA for allowing me the opportunity to share what I've learned about this important topic. I have no financial disclosures, but I do think it's relevant to mention that I work closely with a number of organizations who create CME content assessment tools, including the ABA, SEA, Interhospital Study Group in Anesthesia Education, ACGME, Anesthesia Toolbox, and formerly the AACPD. I've endeavored to remain impartial in this talk, but will say that as an educator, I believe that CME, when done correctly, is effective. I have three main objectives today. I will review the evidence on CME efficacy, explore modifiers of CME impact, and identify future directions for research and development in CME. This talk will time straight close to the topic that Dr. McEvoy will be covering on adult learning, but we've shared content in an effort to minimize overlap. I would like to acknowledge from the outset that this talk would not be possible without the generous contributions of the following individuals who are thought leaders in this area: Dr. Ann Harmon of the ABA, Dr. Rowan Laughlin of the University of Michigan, and Dr. Julie Huffmeyer of the University of Virginia. I interviewed each of them in the preparation of this discussion, and they graciously provided information, graphics, and feedback. Their work is truly changing the landscape in this arena. Towards the end of the talk, I will also share some of my own work, which explores concepts of skill decay in an effort to demonstrate that properly orchestrated CME can reduce skill loss over time. We'll begin in looking at a landmark article from 1999 where Davis and colleagues presented in JAMA a review and meta-analysis of existing CME assessment. This review studied multiple databases and identified 14 relevant studies, 9 of which showed positive practice changes and 3 of 4 of which showed improved healthcare outcomes. This review observed that most studies were poorly done and that the vast majority of CME was conducted through didactic lecture format. Standard lecture-based CME showed no significant effect when effect sizes were calculated, but interactive and mixed educational sessions had a significant impact on practice overall. Let's fast forward 20 years, and in 2009, the American College of Chest Physicians published an evidence-based educational guideline on the impact of CME on knowledge and application of psychomotor skills. This expert panel reviewed nearly 140 articles using the AHRQ guidelines and identified 15 as relevant, 12 on knowledge application and 3 on skills. All but one of the knowledge application articles demonstrated improvements. The findings supported that CME aids in the application of knowledge at a level of 1C evidence. There was not enough data to support which modalities were best to facilitate education, but multiple exposures were suggested at a grade 2C evidence. Given the paucity of studies, there were few inconclusive evidence of psychomotor skill gain. I want to take the next few slides to explore some learner factors moderating the impact of CME. These are relevant to our discussion because they both modify the reception of CME by learners and the effects on the educational approaches that Dr. McEvoy will speak about next. These factors, including learner engagement and self-reflection, have proven difficult to assess in the past, but the next few studies shed some light on them. So in a recent study, there was an examination of the relationship between learner engagement and teaching effectiveness. While engaged learning improves educational outcomes, measuring engagement has proven difficult. But this cross-sectional study assessed CME learner engagement using a novel learner engagement instrument, or LEI. The instrument was developed after a careful review of the literature as part of an expert iterative process. A number of steps were taken to promote validity, and associations were explored between the LEI instrument and a previously validated CME teaching effectiveness instrument. After presentations at the National CME Conference, participants completed both instruments and correlations were drawn between the two. Overall, the scores were strongly correlated with an R value of 0.80. The internal consistency and reliability for the LEI instrument was excellent with a Cornbox alpha of 0.96. Engagement was therefore strongly felt to be related to teaching effectiveness by this group, and this promoted the importance of identifying more engaging and interactive methods for presenting CME. In another cross-sectional study, the relationship between teaching effectiveness and self-reflection and continuing mental education was explored. These investigators sought associations between presenter effectiveness and participant self-reflection in conference format CME. They evaluated both groups at a national CME conference. In a design similar to the previous one we discussed, participants completed the same CME teaching effectiveness ratings, but this time they used self-reflectiveness scores after each presentation. There was a moderate to large correlation between CME teaching effectiveness scores and self-reflection scores for most presentations, about 86.9%. The CME reflection scores were higher for clinical cases and audience response presentations. The takeaway is that clinical cases and audience response systems should be incorporated to increase teaching effectiveness and promote self-reflection for CME participants. The most important thing to gauge is the effects of continuing medical education on improving physician clinical care and patient health. In another systematic review that spanned 20 years from 1984 to 2004, 26 reviews of CME programs were identified that impact physician behaviors or patient outcomes. Interactive techniques including audits or feedback to providers, outreach on best practices, and reminders to providers were the most effective at changing physician care patterns and patient outcomes. One example is a meta-analysis by Austin et al. Showing that reminders altered physician practices for cervical cancer screening and tetanus immunizations. Practice guidelines and opinion leaders are less effective in this study. Didactic lectures and sharing of printed information had little or no positive impact. To summarize both this work and the global body of work, we know that the most effective CME techniques are interactive in nature, but we still use the least effective, such as lecturing. Unfortunately, as we know, the pandemic has only exacerbated existing trends in CME delivery, as it's technically challenging to provide interactivity while maintaining high production quality expected for national and international conferences. Given what we know is effective, we should consider how these approaches are being integrated and what's new on the horizon to help providers grow and learn in practice. In terms of an evidence-based defining the efficacy of an intermittent testing-based approach to maintenance of certification, the ABA studied this issue by comparing incidence of license actions before and after the implementation of a time-limited test-based recertification process. They also explored the impact of a voluntary participation in maintenance of certification for those physicians credentialed prior to the requirement for maintenance of certification and who were thus exempted from it. Time-limited certificates, indicated by the black line in this figure, were not associated with a difference in license actions overall. This is in line with existing research that an instrument typically serves as either a summative assessment, such as this one, which demonstrates learning, or a formative assessment that's aimed at enhancing learning. Voluntary participation in maintenance of certification, as indicated by the blue line in this figure, was, however, associated with a lower incidence of license actions. Interestingly, amongst the cohort required to complete maintenance of certification, failure to complete that maintenance of certification requirements in a timely fashion was associated with a higher incidence of license actions than for those completing the requirements. In my discussions with Dr. Ann Harmon, the Chief Assessment Officer of the ABA, she articulated the belief that boards should have a twofold purpose. The first purpose, illustrated to the left of the slide, is as gatekeeper prior to the certification of individuals in order to protect the public and the profession. Maintenance of certification was originally conceived in this light to ensure that providers met minimum certification standards. The mechanism included participating in educational offerings and passing periodic exams. The focus of this approach to maintenance of certification is to apply maintenance of certification as a proxy for clinical competence in order to identify physicians not meeting professional standards. Unfortunately, this approach does not capture elements outside of knowledge for the most part. In the evolution of maintenance of certification, once someone has met the standard, however, the board should no longer strictly act as a gatekeeper. They should be, in the words of Dr. Harmon, the best partner in keeping the practitioner up to date. This enhancement in provider quality aims to shift the curve of practicing physicians towards prevalently high care, as illustrated on the right of the slide. Based on our discussions today so far and in other literature, we know that the natural trajectory for knowledge and application of knowledge is to decline over time if no efforts are made to improve them. The overall goal in this newer MOCA paradigm, therefore, is to use CME as a vehicle to enhance clinical performance over time. Given the explosion of new knowledge that makes learning difficult to keep up with, Dr. Harmon shared with me that the ABA wants to help diplomates actively curate information to know what is important. For example, twice a year, a MOCA Minute Committee identifies questions that demonstrate a knowledge gap in our community and shares this with other organizations responsible for planning CME, as well as using it internally to enhance the MOCA Minute experience. This reimagining of MOCA within our specialty involved the elimination of those periodic high-stakes exams and replacement with continuously administered CME questions. The rationale for this shift will be discussed further in Dr. McEvoy's talk, but suffice it to say it's grounded in sound educational theory aimed at enhancing growth of knowledge as a proxy for clinical practice. In an effort to understand the efficacy of this approach, the ABA undertook a similar study of MOCA 2.0 participants, exploring the relationship between the completion, timely compliance, and board actions amongst MOCA participants and non-participants. With the MOCA Minute approach, both timely participation and passing demonstrated a modest decrease in state medical license actions. This mirrors a trend seen in other specialties such as internal medicine. Interestingly, this study also demonstrated a relationship between degree of participation and license actions, with early versus late adopters and those that completed all 120 questions versus those that did not, having gaps in their relationships to medical license action. The positive predictive value of these was 2.5% and the negative predictive value was 99.1%. At this point, we've taken pains to identify the elements of CME that provide the highest impact on provider performance and patient outcomes, the importance of promoting engagement and reflection, and the interactive nature of CME and physician license actions. While these are all critical pieces of evidence to demonstrate the value of CME, this research has shown a number of gaps in terms of demonstrating the correlation of CME and provider performance. I would now like to move on to discuss emerging evidence that seeks to delineate the impact of on a more individualized level. In order to better define the impact of CME on individual provider performance, a group from the University of Michigan and other institutions has taken steps to link the outcome data to board certification and MOCA performance. The faculty team includes Dr. Benjamin Cloud, Douglas Coughlin, Nirav Shah, Sachin Ketterpal, Lauren Rocklin, and from the ABA, Hua-Ping Sung, Stacy Diner, and Alex Mercario. This research was done as part of a FAIR ABA research grant. In the preparation for this talk, I reviewed the data with Dr. Rocklin and got her perspectives on the project. This project ultimately seeks to see if MOCA participation is associated with clinical performance amongst anesthesiologists participating in the Anesthesiology Performance Improvement and Reporting Exchange, also known as ASPIRE, which is the quality improvement arm of the Multi-Center Perioperative Outcomes Group, MPOG. In order to conduct this project while maintaining anesthesiologist privacy, the group needed to combine de-identified ABA and MPOG data. While protecting the privacy and security of the participants' personal data, this team developed an approach to data exchange between the APA and MPOG, which maximized matching of data. In an initial phase presented at the ASA meeting in October, they were able to match 91.8% of University of Michigan anesthesiologists between the ABA and MPOG databases. They now have expanded this work to include all anesthesiologists in the state of Michigan with similar matching success. They then looked at anesthesiologists certified between 1994 and 2005 using the ASPIRE database to evaluate physician clinical performance across participating institutions. They explored 7 metrics, 6 process, and 1 outcome, looking at frequency of events in relationship to board certification. They seek to develop a system that allows providers to compare their performance to that of their local colleagues, provide targeted CME, and ultimately demonstrate quality improvement relevant to their personal practice. They're presently analyzing their data related to the ASPIRE metrics. These yield results that are very interesting, such as the violin plot pictured to the right, with some of their performance measures of interest highlighted. Preliminary results suggest that while there may not be a relationship to at the composite outcome level, that some specific outcomes may in fact be related to MOCA participation. In the interest in time and out of respect for this group's work, I will not attempt to provide further details, although I am quite eager to see the final results of this exciting project. Dr. Julie Huffmeyer from University of Virginia is exploring the association between continuing medical education for anesthesiologists via MOCA Minute and clinical performance. She believes that there may be a link between anesthesiologists' responses to MOCA Minute questions and their clinical performance. She is similarly using the ASPIRE database metrics, but identifying which MOCA Minute topics specifically are most strongly associated with clinical performance of these ASPIRE metrics. Dr. Huffmeyer aims to provide targeted MOCA Minute questions to anesthesiologists and ultimately improve their clinical practices in this way. Her research is ongoing, and I can't wait to see the results. While there is evidence on improvement of knowledge application, there is historically little direct evidence for improvement of psychomotor skills through CME. Studies have been unrandomized, involve simple procedures, or mixed instructional techniques, limiting their conclusions. We do know that simulation can improve some skills, but the initial interval required may vary, and currently there are no approaches to individualize this method of teaching. It's also unclear how the complexity of a skill interacts with its durability of training. We know from the example of ACLS that technical skill decay can occur over as little as 3 to 6 months, and there's therefore need to develop approaches that are more durable. You will hear about some of these strategies, including deliberate practice and mastery learning, from Dr. McEvoy in his presentation. There's a call across interventional specialties for enhanced assessment of technical and psychomotor skills. Indeed, in surgery, this has been embraced in training and is being sought for practicing clinicians. In anesthesiology, I'm part of a team exploring the impact and the extent of initial training and follow-up training on maintenance of technical skills. We're studying growth and decay curves of technical skills to determine what factors can enhance acquisition of skills, what determines the level to which skills should be trained to ensure safe practice in either a supervised or independent role, and how often skills need to be practiced or retrained to avoid excessive decay or degradation of skills. We teach through courses that include multimodal approaches like interactive modules, focused lectures, case-based discussions, and abundant hands-on training with simulators and live models. For assessment, we use a combination of motion tracking, knowledge tests, workflow OSCEs, and procedural checklists to document competency and expertise. The figure on the right of the slide shows the use of motion tracking sensors in defined segments of central line placement, both on the hand and on the ultrasound probe. We use both aggregate performance data and segmented performance data to help learners improve trial to trial in some of these studies. I'll show you just one example of initial learning curves to get a sense of what I'm talking about in the context of CME. First, we can observe in the example of central line training in a cohort of interns. After baseline training, their skills accrued, of course, to the board. This example charts both path length, which declines over time with trials, and expert ratings, which improve for a variety of metrics over time. By 8 trials on average, novice was performed within a standard deviation of experts on metrics including total time, path length, accelerations, and rotational sum. 9 months later, we can compare their skills in orange with their original skills in green at baseline. At the bottom of the slide, the total time is not different from baseline. On the right of the slide, we see changes mostly in probe motion declining, but similarly or slightly improved patterns of motion in the needling hand. This work deserves further examination and larger samples to validate it. Just last week, we were able to obtain some follow-up data from Navy SEALs and Special Operations combat medics who participated in one of our 5-day interactive point-of-care ultrasound courses at different times over the past 14 months. These highly trained medics had some exposure to POCUS in the past, and thus this course served as somewhat of a CME experience for them. We're seeking to quantify the interactions of baseline skills, exposure of achievement of mastery endpoints during the course, and frequency of clinical use or practice after the course. While datasets are currently small, they suggest an intuitive interaction between time away from the course and decay of skills. We're now exploring whether the duration of refresher training required to help these providers regain their skills will be substantial, and whether the optimal training interval will be longer or shorter in order to balance the skill decay with other training requirements for these individuals. We are similarly collecting data on trainees and faculty across a number of procedures and specialties to try to identify similarities and differences between skill development and decay in these cohorts. It's our ultimate goal to develop individualized training and customized performance feedback to speed skill development, enhance retention, and deploy individualized CME of appropriate duration and complexity to address each of these learners' needs. In conclusion, we've navigated a very complex labyrinth together. We've seen that CME impacts knowledge and patient care outcomes when properly done. We've also reviewed key concepts including interactivity, reflection, and engagement that impact and the enhancement of CME, so I hope we use these in the discussion to bolster our session. We looked at some emerging approaches to define the role of CME on individual provider performance and the potential for customized CME, and we touched on technical skill maintenance and the use of objective motion data to evaluate proper intervals for training. Dr. McEvoy will now speak to us about best approaches for training adult learners, and I, for one, will be paying close attention to see what approaches I should be integrating into my courses. Thank you for your attention.
Hello, everyone. My name is Matt McEvoy from Vanderbilt University. I want to say thanks so much to the AUA for inviting me to give this talk virtually. And I do hope that this leads to a really robust live Q&A. I'm going to be talking about adult learners and what works according to the evidence. Now, I set my timer on myself so I don't go over, but in the next 20 minutes or so, my goal is to talk about this, but I'm only going to be able to actually present a part of the evidence. And then again, as I said, hopefully it will lead to some good questions during the Q&A session. Financial relationships. I've had a relationship with Takeda Pharmaceuticals, being on their advisory board. That's not currently active, but it occurred within the past few years, and I will not include discussion of off-label or investigational use items. By the end of this session, I hope that you can describe the master adaptive learner or the master adaptive adult learner and really discuss a couple of concepts. I can't cover everything, but some that are really emerging is microlearning, particularly with spaced education, and then something called rapid cycle deliberate practice. That's an advancement on what we used to think about just as deliberate practice, and then consider how this might apply to the Kirkpatrick levels of learning. So the master adaptive learner, and this is really what we should all be, certainly as faculty, we want our trainees to be, we would like everyone in our practices to be, and it really has these 4 steps of planning, learning, assessing, and adjusting. And in planning, that's where you question, you prioritize, you set goals for yourself. In learning, it's where you do some critical appraisal of the evidence and learning strategies come into play, and I'll come back to that. In the assessing, it's really where you get some external feedback and you've got some informed self-assessment of how do I keep growing, and then adjusting. It's, is it individual versus system implementation, routine versus novel? That can get into, is it medical knowledge? Is it skills? And those sorts of things. For this talk today, I'm really going to be focusing on some learning strategies and maybe encouraging you to implement these in your departments or in your practices. Now, there's going to be 2 axes here for really creating an educational intersection. I'm going to first talk about technique and get to the other one at the very end, which is called content. So within techniques that we know work, I'm going to focus on spaced education, partnered with retrieval with feedback, which is really retrieval, meaning how are we getting someone to go get that knowledge? It can be through a question, it could be through a dialogue, et cetera. But this is much more active learning rather than just sitting and receiving education. And then I'm going to talk about deliberate practice. Now, to start out with more of the deliberate practice, in 2014, so this isn't that long ago, only 8 years ago, this paper came out from a group, and they were looking at pediatric resident resuscitation skills. And instead of traditional deliberate practice, which would maybe be where you do a sim and then you have this really long debrief and you hope there's some change, and you could then add in with deliberate practice, maybe a little bit more skills practice. They said, how do we build from novice to competent to proficient to really some skill mastery by applying this new pedagogical approach? And so what they did is they had this rapid cycle deliberate practice program, and these were called the first 5-minute cases. And it was going to not let these simulations go really long, but you were going to have a short case. It might even get interrupted, and then someone gets to, it's taking much more of a coaching approach where the expert may come in and say, let's stop, let's think about what we've learned, let's make some adjustments. And we go from something that is, bag mask ventilation, very simple, to then something that's a little bit more complex and requires maybe some sort of airway adjunct. And then you get into beyond the airway. Now you have someone who's bradycardic. Then you're leading the team and someone has PEA. And then you move up to needing to shock somebody, have defibrillation meds, et cetera. And so it's this rapid cycle of building all of this happening in a short period of time, as opposed to having one maybe longer event with this really long debrief afterwards. They had clinically focused outcomes in this. This was randomized controlled trial. And what they looked at is this was pre-intervention and post-intervention, and the time elapsed from the onset of pulseless VTACs to the initiation of chest compressions. And it went from about 34% to 71% in the first minute. And they still stay separated based upon the type of, whether it was before this type of training or after this type of training. Same thing with the looking at whether they had how long of time was before they actually shocked the patient who had a condition in which the patient should receive defibrillation. And you can see pre-intervention, there was quite a significant delay. Post-intervention, they were doing it almost all within the appropriate time frame. And so really a tenfold decrease. And so this is getting to this rapid cycle deliberate practice and having things that really lead to clinically important outcomes. Now, this was all simulation, but the next step, of course, would be to move towards testing it in the clinical arena. And so what is this cycle? You get folks who are novice, and they do some sort of novice performance, like we said, bag mask ventilation, and then they get some brief feedback, and then you talk about what would it be to go to the next level. And so then they get competent, same thing, brief feedback, then they get proficient, and you keep moving through this with increasing difficulty. And once they get mastery on sort of this first level of overall skill, what you would want them to do, say being able to manage a pulseless arrest, you then increase the difficulty, go to the next level. So where could you see the application of this sort of thing, where there's practicing either skills of technical skills, non-technical skills, and then rapidly going through some debriefs, debriefs, adjustment? Well, this could be things like crisis resource management, which we just talked about, often going to be in the simulation world. This certainly could be an ultrasound guided regional anesthesia, that you could take this approach on your regional rotations. You could take this really in any skills-based approach, and not just let the residents have the experience or let yourself have an experience, but say, I'm going to put together a sequence of these things in rapid succession so that I can go from novice to competent to proficient to mastery. And that's really what the evidence is bearing out as being a possibility. And I would say, I think for those of you who are not POCUS certified, and I'm actually not involved with this program, although being a learner, I've been quite impressed with how they've put it together. The ASA has their new POCUS certification. And when you get to the point of actually performing and acquiring the images, I think if you applied this rapid cycle deliberate practice, that's when you're going to see that you're gaining the skills, and those skills really become sticky, that you can actually get to some, not just stay at the novice level and every couple of weeks you're doing one or two point of care ultrasound exams. But if you do this in a way where you're doing the exam, you're getting some feedback from a mentor, and it's really taking on much more coaching rather than instructor, it helps people advance tremendously. Now, that was rapid cycle deliberate practice, and it has application in the real world, and there's evidence behind it, and structuring learning opportunities around that, I think, can be important, and particularly for those of us who are out in practice and saying, I want to gain this new skill. I think it's particularly applicable to technical and some non-technical skills in high stress situations or in more procedure-based situations. Now, to move over to spaced education, we're going to talk about that a little bit, and this idea of retrieval with feedback. So if you look at the modern learner, okay, this is just some really interesting stuff that you can find out there. In a typical work week, you have about 1% of your time that someone can really focus on training and development. Learners are overwhelmed. We know that, and we've seen a lot of that through the COVID pandemic. If you look early in the days of the internet, someone might get online 5 times a day. Today, it's 27 times, so people can be distracted. Most learners don't want to watch a video or really engage in something that's longer than 4 minutes, maybe up to about 10, but that even takes some real decidedness and them wanting to learn that topic. If you look at people unlock their smartphones on average 9 times every hour. I have teenagers, and it's a whole lot more than that, but certainly even for adult learners, that's true. 2/3 of knowledge-based workers, that means people who are working with executive functioning and cognitive skills rather than only working from more of a physical labor perspective, complain that they don't have time to do their jobs. And so this could go on, but really what we know is adult learners engage more, learn more, and retain more through what's called micro learning. And it's these smaller nuggets of information that come to them. It's the same way that when we check our news apps, the ESPN app, other things in the day, we're constantly being fed nuggets of information, and really utilizing that form of knowledge consumption is what's being talked about here. So if you think about adult learning, micro versus macro learning, this is, I need help now, or you're telling me to operate within the system of what I'm doing. This is some information that I need. This is very different, and it doesn't take away from, I want to go to a master class and learn how to cook something new, or maybe become, a mixologist, or I want to do something. So it's not taking away from the fact that macro learning can learn for the really interested person, but it's saying that we should move away much more so from passive learning, from really extended and long learning engagements when folks don't have that time. It should be things that are more engaging, like videos or questions, those sorts of things. I'm going to show you that in a second. And the content should really be sorted for the learner already and be of good quality and really relevant to what they're doing. Now, as Dwight would say, PowerPoint is boring. It's funny that I'm actually going through a PowerPoint, giving you a talk on learning, telling you that you shouldn't be using PowerPoints, but bear with me for the moment. So rather than lots of bottoms and seats CME, and this may challenge our traditional grand rounds. This may challenge a lot of the things that we think are ways that we're supposed to do education just because they're sort of sacred within our system. What I would suggest is that we need to take advantage of what I call the intermoments, almost like the interstitium of life. Where are these between spaces that if we link into at least some of them, we can create this longitudinal learning in these micro learning events. So evidence would suggest that microlearning improves focus and supports long-term retention by up to 80%. But what you're seeing here is you might see on day 2 of a week, day 4 of a week, and day 6 of a week, you're getting this small knowledge nugget. Remember, short period of time, a burst of information in an engaging way. And that really is spaced education. And to simplify that, traditionally you get this big event learning bolus, and that could be an hour of lecture. It could be 2 hours. It can be some of these really all day type of seminars that we're going on to try to cram stuff in. The problem with that is we know that's not nearly as effective as if what you do is you break that up and you put it into a bunch of different learning events. Now, spaced education can be any modality of repeated exposure over time. It really can be any duration, but micro learning tends to be like 4 to 12 minutes, sometimes even shorter. And it can be any length of spacing from several hours apart to days or weeks apart. But the idea is once you begin to encode some of this information, you then ask the learner to go back, retrieve some of that, bring it into their active memory, and really do something with that information. And then it locks it in there more because it's broken up and spaced over time. Now, you may say, well, that's great. So they can only learn one thing at a time. And there's this principle that is in there called interleaving. And so you can take different topics. And while topic 1 is spaced out like this, you can have this topic 2 in there and then topic 3. So there can be a lot of events going on in these small micro learning pieces. And that's the idea of what you want to do is you want to make learning a very frequent event, but you're doing it in such a way that it's a little bit more convenient for the adult learner. It matches our lives, and it takes advantage of what we know to be true in modern pedagogical approaches for improving knowledge acquisition, knowledge retention, and then knowledge application. Truthfully, if I had to summarize it, the evidence is spaced education works, and it is more efficient than traditional learning by 5 to 10 times. This has been tested from elementary, middle, and high school kids to college age kids into graduate education and all the way into people in practice. We've tested it ourselves with radiologists, anesthesiologists. There's a group led by Kerfoot that did this with urologists. And so it actually has been shown to work and not only improve knowledge acquisition and retention, but in some of the studies actually to change clinical practice. So I'm going to talk to you about the work that we're doing at Vanderbilt. And this is similar to what you might see with, say, the Mocha Minute or the ABA Go app. For us, though, we actually push the content to people rather than you having to go and retrieve it yourself. But you get a workplace relevant question. You read the question, answer it. You get an evidence-based medicine answer. So it's really based a rationale that's based on the literature. You actually have links out if you want to do deeper learning. So that, remember, there can be micro learning, but sometimes people say, I really want to go and learn that. And now you've engaged that adult learner and they're going to go dig deeper into something. And so they can go and do that. And in this case, there's a PDF of an article that could be linked to. One thing that's super, super important with this, whether it is the ABA Go, there's multiple apps that out there. We created one at Vanderbilt that we use for our internal learning, but this is testing for learning, not testing of learning. And that's very, very important. The psychometrics of the questions don't have to be as good. It's just that that question is a hook to do that retrieval and then with feedback. So you have the spaced education. We send these out, one question per day, spaced over time. The question makes you try to go and retrieve some knowledge, and then you get feedback on if you're right or wrong, and then where you need to learn. We're doing this currently in our department based on the MPOG Aspire quality metrics. We've created a team around this, and we're both sending out these knowledge chunks through this quiz time app that we've created, but also through the MPOG Aspire. What happens is people not only get feedback on that immediate question before them, but they actually get monthly feedback with an email that says, how are they doing in clinical practice? And so in multiple ways, we're creating that learning cycle. And what our team does is goes through and we'll take a topic, in this case, say neuromuscular blockade dosing. We'll do a pilot with some number of our anesthesia providers, and then we send it out to all of our anesthesiologists, residents, fellows, CRNAs, and try to engage the department. We don't require that people participate, but we actually end up having a pretty significant participation. Now, what's our data so far? This paper is in preparation, by the way, currently. Dr. Miklos Kurtai is our director of this and does a phenomenal job. We've got a lot of people involved in this, from our quality and safety director, Paul St. Jacques, to an educator, Dr. Leslie Fowler, to our chief CRNA, Brent Dunworth, content experts on different developments. And so the list of people is really too long to name, but it's a good team that constantly works together to put this together. And what you can see is this is over about 24,000 cases, about 400 physicians and CRNAs. And we had a pre-intervention phase where we're already, just as a department, we were talking about this and we were improving a little bit. Then we had a grand rounds topic and we took a little bit of a step up and we told folks that this quiz time module was coming. We sent the quiz time module out, and then we did a booster. Now we're into a post-intervention phase, but we're still not yet at the 90% goal that we want. But the reason I show this is to show this can be learning at scale, and we're engaging adult learners routinely in the midst of the work they're doing every day. It does not require a lot of time of them. And it seems to us, at least, we have a signal that we're bending the curve and actually changing clinical practice. So the model of learning, what this really is the LHS, or the Learning Healthcare System learning cycle. And that is that we've got some new learning, actionable knowledge we want people to put into practice. That gets adopted or doesn't. We give them feedback through that Aspire framework on, are they doing better in their practice or not? We can actually look at patient outcomes as we employ ones that can be associated, say, with AKI or myocardial injury or post-op nausea and vomiting. And then that gives us new evidence to work with, and then we put it back through that cycle. So that's that model of micro learning in practice. Like I said, there is a plethora of opportunities out there for us to work on. And these are ones that we're going to employ over time. And the MPOG Aspire framework is one that I think is built to do this type of micro learning over time. And then there is the application of this. So I talked about the other one, applications, say with the ASA POCUS certificate or in simulation or ultrasound guided regional anesthesia. Where do we see this come up? Really, the ABA Go, I think, or what MOCA Minute is a terrific example of this, where it engages learners. My understanding is, as far as a maintenance of certification program goes, it's one of the most popular components of any of them that are out there. I've certainly enjoyed it myself. And then we do it within the learning healthcare system. And I think this is something that many more people can employ. And certainly if you wanted to partner with us and gain some of this knowledge or some of these educational modules, we would love to do more research and generate more evidence about the adult learner with you. So the techniques I talked about are deliberate practice or rapid cycle deliberate practice, more for the technical and non-technical skills in some of those environments I talked about. Spaced education is much more so for sort of nuggets of knowledge that then can be applied. But the other axis I think very, very important is these should be case-based or clinically focused and have some immediate application. If you're going to engage the adult learner, what we know is that these techniques matter, but the content that you put into it matters. It should not be esoteric stuff. That's often for that macro learning where someone gets really interested in wanting to go dive deep, deep, deep into things. And that's important too. And that type of learning actually works. But for the ongoing adult learner where the evidence is emerging, is these are some ways to really engage them in a longitudinal fashion. Finally, I'll close with Kirkpatrick levels. We want everyone to enjoy the training and maybe showing did some transfer occur, but really what we care is process and outcome metrics. That's what we care about. And so I think that these areas that I talked to you about today, rapid cycle deliberate practice and spaced education, that utilizes retrieval with feedback in a micro learning environment are going to be some ones that engages the adult learner in the time, space, and the workspace that they have in order to produce this basically constant practice-based learning improvement. So take-home points. The goal is really to have master adaptive learners who want to keep going through that cycle. The goal is to cultivate lifelong adaptive learning with a growth mindset for all adult learners. Micro-learning with spaced education and retrieval with feedback is superior and preferred for medical knowledge acquisition. Rapid cycle deliberate practice is emerging as most likely superior for skills mastery. And I would argue that every training program, department, and practice should consider how to embed these principles in their educational program with the goal of showing improvements in operation, showing value to your institution, as well as patient outcomes. So thank you for your time. I look forward to the Q&A.
Bar to get into the specialty to keep them up to speed instead of trying to eliminate the bad apples, trying to make all the apples good. I'm paraphrasing Anne here, but essentially it's a commitment from the ABA to try to help all providers continue to improve, which I think is refreshing instead of just trying to target people.
John, I guess, can I just give some little context to that question as well? It seems to me I'd like to defend the format for this presentation, for example, since I think you are looking towards advancements in the field and truly sort of, I don't know how you could do that with microlearning. So maybe I'm thinking more of a spectrum, but I see the work of MOCA when it's maintaining minimum standards being very sort of target oriented towards very specific targets. And maybe there being a continuum across that, such that you could defend these kind of formats as being the best when you have people looking towards understanding the advancements in the field. That was really my point, not to reduce the value of microlearning, but to suggest or defend this format when you're trying to advance the field as opposed to maintain a minimum standard.
And Mark, that's a well taken point. I think, for example, the topic that I had, CME, what's the evidence that it works? That's a fairly dense topic to get through. And I couldn't really be, I mean, I could have broken it up into maybe several 7-minute sections, but I think it was important to kind of survey that panoramically. And so there was I think some value to this 20-minute approach, but I'm glad we've sort of moved away from the full hour talks. I did wind up talking faster than I intended and when I re-reviewed it to squeeze things in, but I think, yeah, using some of this lecture format, but understanding that what the limits of human attention are and interspersing it with other approaches, I think are good strategies. I see Dr. McEvoy has joined us.
Yeah, sorry, but I don't know why the link wasn't working and they just had to send me a direct link. So I apologize for joining late. I've been trying for about 45 minutes to get on.
Yeah, not a problem, my friend. We're all having a good time here.
So Dr. Martinelli asked, would the AUA webinars count as that type of learning? And I'm not sure. I think she's on.
Yeah, back to Dr. Ellis's comments about sort of spacing out what we're doing, and I know it's probably not like to the definition per se, but I think that's kind of the same idea to get different topics interspersed throughout the year and not have all the learning focused on at the annual meeting. But I don't know. I think Dr. Baker commented as well, so maybe John, you can speak.
So Dr. Baker also has a question. I presume that spaced learning patterns, pertains to similar or related topics. Thus, if we were to have 30-minute AUA sessions each Thursday evening, then the topics would need to be related, at least over some number of sessions. And can you comment on that approach?
Yeah, and I think I attacked that somewhat tangentially, but I appreciate Keith bringing that to the foreground, because yeah, if you're doing spaced learning, the concept is to either repeat the same thing or ideally ramp up the complexity of something over time. When you're talking about psychomotor skills, either focusing on a different element of the psychomotor skill to build the full suite of skills, or add a layer of complexity with the eye towards keeping the task load relatively constant over time. But with knowledge, same kind of concept, building on something, or at least being connected to something if you're talking about a spaced learning. But the other alternative of making these kind of longitudinal over time instead of a single point in time is just to reduce the fatigue, the Zoom fatigue of long sessions. And I'm open to discussion on those because I see the merits both ways.
And Dr. Goldstein has a question. One, spaced learning and interleaving are proven to increase efficiency and effectiveness of learning. Microlearning is very good to increase factual-based knowledge, but shouldn't we be moving to apply spaced learning and interleaving to simulation-based education? Some programs satisfy the ACGME requirement with 2 hours of training per resident annually. If we were to perform simulation of critical events for all residents quarterly, I believe we would graduate residents with much better abilities to manage critical events, especially important with the older and sicker population.
Yeah, I think there's a lot of value to that. I mean, for my technical skills training now, I tend to do large boot camps up front to get people towards that mastery based, either as a series of sessions or 1 or 2 longer sessions to make sure they reach those mastery thresholds that Dr. McEvoy was speaking about. And then I do spaced learning over time, especially before a major rotation. For example, now I've started an education lab where people come in right before their vascular rotation and practice their arterial lines, and right before their cardiac rotation and practice their central lines, right before OB and practice their epidurals. And we do, again, a refresher. We're kind of randomizing people to look at whether a classic 3 to 5 trial approach is better than pushing them to a mastery level with hand motion metrics that are within a standard deviation of experts. Or if that tried and true 3 to 5 is close enough for most people. And so we hope to have data on that over the next year or so.
So Dr. Nemmergut had a comment that I think will end us really well, which was that he really enjoyed both presentations. I completely agree. I thank everyone for their attention, for their interest. And I especially thank Dr. Mitchell, Dr. McEvoy for your really thought-provoking presentations, and everyone on the call for the very engaging discussion. Thank you so much.
Thanks, everybody. It's a pleasure to be here.
I think you're on mute, Dr. McEvoy. Thanks, everyone. I'll let everybody head to the next session. Thank you so much.
Thank you.
Have a great rest of the meeting, and I'll see everyone soon.
Thank you for moderating.
Oh, thank you. You guys were really interesting, really terrific presentations, generated terrific comments.
Hi, John. Really
Hi,
great
John.
session.
Thank you. I think as usual, Sheldon, I think your points are spot on and see through all of the forest or the trees and really kind of get at the core points, which is where I think we need to go as a specialty.
I sort of see such a need for improved education these days, and yet the workforce and the stress of the shortages of anesthesiologists just making it so hard to focus on education.
Yeah, and that's why I try to bring the training close to the providers, having it near the OR. I try to make the sessions short, and I try to focus on the just-in-time learning for knowledge and skills that are going to be relevant for the trainees or the providers right before they're going to need them, ideally within a couple of days to a week. And I think that works pretty well for at least for our learner cohorts. They're much happier with that than saying, oh, I have to go to a quarterly workshop for 2 hours to do this. They're like, oh, I can hop by for 45 minutes after my cases are over, drill on this technical skill until I'm at level, and then go do it tomorrow. Seems to be a really good model for people. And I'm hoping that the data that we're collecting shows that, but if not, we'll keep experimenting with the intervals and the efforts and see what we get.
But that's just really excellent. I mean, you have that worked out so that if a resident knows they're doing 3 cases tomorrow that require central lines, they can go to you at 4:30 in the afternoon and get a workshop on central line placement?
Well, we have 2 mechanisms. One is before a major case rotation. So before they come on cardiac, vascular, OB, regional, they're required to come by our skills lab within a month before, but ideally within 2 weeks before we schedule them for a proctored session to do technical skills training, which previously was just like see one, do one, practice a couple times and go. Right. Now we're elevating that based on our hand motion data and other OSCEs and workflow OSCEs or an interactive online modules to make sure they level up to that mastery-based level, whatever we set our cut points at, which we're still working on setting the cut points this year. But the vision is we'll make them go to the cut points before they're released onto live patient work.
Wow, that's really cutting edge.
Right. And then to supplement up, they have badge access 24/7 to our education lab. So if they know they're doing something and they feel like they're not ready to do it, they can pop by and practice, and they'll have access to, obviously, there are near peer trainers that do an education rotation, so are available on a regular basis, or they can book a time with the faculty mentor, or they can just watch YouTube and practice it or our suite of online videos and training modalities and practice it themselves. Not with the motion data, but at least practice it on the task trainers that we have available to them.
Are your online videos available for those outside your program?
Yeah, I'm happy to share what we have with other folks. We're always trying to build more and train better. You know, some of the stuff that's out there on the New England Journal website or Open Anesthesia is excellent. So we haven't recreated the wheel on everything, but especially for POCUS stuff, we built our own before. Now a lot of people have POCUS videos and things, for example, but we have a whole suite of POCUS stuff, which I think is a good prototypical psychomotor skill that's really challenging for our learners to pick up and doesn't get the use that some of the other skills do.
Have you seen the work on the easy echo exam?
I have, that Nibras has done up at Albany.
That's very interesting.
His approach is very interesting, and it's interesting because I think the subcostal view for me is one of the more technically challenging views, but I like his premise that if you can teach that one view and teach it well, then people then can branch out from there. I've been interested in doing a study with him comparing sort of his approach with this easy view to my more conventional approach of teaching, the suite of standard views and seeing, whose learners are doing better. I think there's a great opportunity there to explore that, to see which teaching paradigm makes the most sense, and then adapt from there. But yes, I think his work is extremely compelling.
Yeah. All right.
Great. Well, good to see you, Sheldon. I hope you enjoy the rest of the meeting, and we should catch up soon, my friend.
Same. Sounds good. Thank you. Have a great day.
Thank you so much. Have a great day. Thanks. It was great talking with both of you.